Are Prabhu and Dr. Chandramouli here?
Yes, sir, I'm here, sir. Am I audible?
Yeah, you are audible.
You are ready?
Has Prabhu joined in?
Prabhu is not yet.
No.
Sir, I have joined, sir. Yes.
Dr.
I have joined, sir.
Dr. Chandramouli, you are ready with your presentation?
Prabhu is not here. Not yet.
Dr. Chandramouli, you are ready with your presentation?
Yes, sir, I am.
Okay. I'll allow screen sharing for you, okay?
Sure, sir.
Okay.
Prabhu is just joining now. I think we can start.
It's 8, sir.
Yeah, it is 8 o'clock. We can start.
So, good evening, respected senior faculty members, esteemed colleagues, and all pediatric surgery trainees. I, Dr. Vijay Kundal, Additional Professor, Pediatric Surgery in Jammu, on behalf of the editorial board, JIPS, welcome you all on this first ever online meeting named as JIPS Abhigyan Journal Club Episode 1. So it's an honor to have such a passionate and dedicated group gathered here on this virtual mode today to discuss different research articles related to the pediatric surgical care. We believe together we shall delve into cutting edge research, share experiences, and ultimately enhance our collective understanding of pediatric surgical research. So today we will be discussing 3 articles published in a recent issue of JIPS. So before that, I would like to invite our esteemed editor-in-chief of JIPS, Dr. Rasik Shah, sir, for opening up the online session.
Yeah. Thank you, Vijay, for introducing the today's journal club. So I am very happy today because this idea of starting a journal club online was suggested by Dr. Vaibhav Pandey when he was participating with IAP people, which is, I think, less than a month or so now. And we are able to execute this program within this time period. So I'm very happy about that. And I'm more happy because here I got the idea, and in execution, everybody has helped, starting from coordinators, moderators, presenters, Dr. Vikesh as well as Dr. Ramesh Babu, IAPS officials. So my work has become relatively easy. The Manoj and Vijay have been a good help in executing day-to-day activities of JIAPS, and the entire team of the reviewer and everybody is contributing to the best possible way. And because of that, we are able to decrease the time period of decision making and publication both ways. The details will come in the editorial of the May issue. Some of the details, not everything. So without wasting the time, we will. I will tell Vijay to take over and continue with the proceedings as decided earlier.
We'd like to welcome our President IAPS, Dr. Ramesh Babu sir also, and Secretary Dr. Vikesh Agarwal on the event.
Thank you. I mean, I really congratulate Dr. Rasik Shah for this excellent initiative, and for Vijay Kundal, Vikesh, and everybody to support him in a big way. I also request that, in this process, if we can create infographics for each article, we can make it popular more and then make it more reachable and then attract more people to this particular thing. So at least for these 3 articles, we should start with infographics.
Thank you, sir. We'll be starting with our first article. Moderators for the session are Dr. Kanishka Das sir and Dr. Sanjay Kulshesta sir. Our first article will be makeshift shunts in extrahepatic portal vein obstruction in pediatric population. Our presenter will be Dr. Chandramouli and Dr. Prabodh. Dr. Vireshwar Bhatnagar sir will also be there for moderating the session.
Are my slides visible? I am clearly audible?
Yeah, your slides are visible. I think
Yes.
you may start.
Okay, thank you. A very good evening, respected chairpersons, seniors and colleagues. Warm greetings from AIMS Delhi. It's a privilege to inaugurate this new initiative, JIPS Abhigyan, as its first presenter. My presentation will focus on the pivotal role of shunts in managing extrahepatic portal venous obstruction. This discussion is indebted to the dedication and expertise of the esteemed stalwarts in this field, such as Professor Bhatnagar sir. Professor Dr. Prabodh Goyal sir was once serving as a senior resident under Professor Bhatnagar, contributed significantly to laying the groundworks on understanding the management in portal hypertension. Additionally, we are fortunate to have Dr. Anjan Dua, who continues to make substantial contribution to this field through his ongoing research efforts. Their collective presence in this meeting underscores the importance of the collaboration and shared knowledge in advancing our understanding and treatment in extrahepatic portal hypertension. We all understand that prerequisite to create a shunt in extrahepatic portal venous obstruction is a patent splenic vein and the presence of renal vein. Sometimes the splenic vein gets thrombosed and an anastomosis can't be made. Through this publication, our department has tried to share such experiences in patients with EHPVO and let the young pediatric surgeons to know about the lesser known shunts and to assess their efficacy. So this was a prospective cohort study over a 36 years period. 138 children were of extrahepatic portal venous obstructions was operated, of whom in 6 patients makeshift shunt were considered necessary. Among this shunt, a side-to-side right gastroepiploic to left renal vein shunt and a superior mesenteric vein to IVC shunt was done using a saphenous graft. In the other, inferior mesenteric vein was used in 4 patients, of whom 2 patients with left renal vein and 2 with inferior vena cava shunts. All these patients were assessed for the shunt patency at 14 days or before discharge, whichever was earlier. They were followed up 3 monthly for 2 visits and then 6 monthly. One of the patients had cholangiopathy, one had absent left kidney, and one had cross-fuse ectopic left kidney. The presentations were classical for extrahepatic portal venous obstruction. The findings were all diagnosed on ultrasound colored Doppler and confirmed on CT photogram. In children, in the first children with the vascular anatomy was quite a bit different, with a thrombosed portal vein marked as 1, the right gastroepiploic vein marked as 2. Number 3 is not the splenic vein, but it's lower down, which is thrombosed. Number 3 is the prominent gastroepiploic arcade, continuing as the left gastroepiploic vein, as in 4. 6 is the inferior mesenteric vein, and the 7 is the superior mesenteric vein. This was the intraoperative photograph published in JIPS as well, showing a tortuous and dilated gastroepiploic vein. A side-to-side anastomosis was done between the right gastroepiploic and the left renal vein. Portal pressure was measured in all cases by inserting a wide bore cannula in a large caliber omental vein. The pressure dropped post-shunt from 38 to 21 millimeter of mercury. The child was symptom-free and the shunt was patent on follow-up. To add to this, these patients were also included in another study which compared nitric oxide, which dropped post-shunt surgery, and the nitric oxide level remained low in follow-up patients. These results has also been published separately. The second case was another interesting case with a left to right crossed fuse renal ectopia. A side-to-side shunt was constructed between the inferior mesenteric vein and the left renal vein. The series of pictures depicts the anastomosis, which is also published in JIPS. Similarly, the portal pressure dropped and the child was asymptomatic on follow-up. The third case was peculiar with the patent splenic vein, but it appeared thrombosed with multiple YTs patches and irregularities, and the vein did not look cylindrical for the anastomosis to hold. So the saphenous vein was harvested from the thigh, It was split longitudinally and retubularized in a spiral fashion so that the caliber increased to around 1 centimeter, and a new conduit was created between the superior mesenteric vein and the inferior vena cava using this saphenous venous graft. In the follow-up, she was also doing great. The portal pressure dropped from 31 to 24, and the shunt was patent on follow-up. In the fourth patient, the splenic vein was similarly appearing thrombosed, and inferior mesenteric vein to left renal vein anastomosis was done. He was also doing well on follow-up. The fifth patient, the splenic vein and the superior mesenteric vein was similarly thrombosed as shown in the CT protogram, and the inferior mesenteric vein was dilated. However, the left kidney was absent. So how do I do the anastomosis? So plan was to do inferior mesenteric vein and the IVC anastomosis. So it was done, a wide anastomosis was done. The portal pressure significantly dropped, and the shunt was patent on follow-up with the shunt was patent on initial follow-up, but the child again presented with the features of adhesive intestinal obstruction later. However, he was managed conservatively, and on 6-month follow-up, the shunt was showing blockage on colored Doppler. However, there was no recurrence of symptom on 2.5 years of follow-up. The last patient presented with the rectal bleeding predominantly. The splenic vein was thrombosed. The inferior mesenteric vein and the inferior vena cava anastomosis was done, and child remained symptom-free on follow-up. Overall, all these patients had shown a significant drop in the portal pressure, with a mean drop of 13.3 millimeter of mercury in the decline in the portal pressure. The shunts were patent in 5 of the 6 patients, and there was significant good clinical response. There was a good clinical response, and even the patient with portal cholangiopathy had reversed. So the principle of shunt surgery the principle of shunt surgery is to treat the varices, which should target to decrease the portal pressure either by shunting the blood away from the portal circulation into the systemic circulation or via devascularization. So a shunt could be done in one end of the spectrum or a devascularization on the other end of the spectrum. So in between, what is the treatment to be done? The lesser explored part are the makeshift shunts, and these shunts could bail out the possibility. Thank you so much for providing me this platform to present.
Kanishka sir, please.
Yes, I think it was a nice twist presentation, and the important features of this paper, besides the information that it provides about a lesser known entity, is also the excellent imaging that goes with the case descriptions. The case descriptions are very crisp, to the point, and the discussion is also very pertinent to the clinical scenarios and the way out in these difficult situations. I don't know whether we have any questions yet in the chat box. I don't see any questions.
Sir, there is one question.
Yes,
Selection of the procedure was pre-op or intra-op?
yes. Very interesting question. I think you would go ahead and answer that. I will just add one more question, which you can take along with that. Is your follow-up is 1.4, 1.5 or something to 4 years, with a mean somewhere there. Now, generally, we say that in these shunts, it's a long-term patency that one looks for, and that is where it significantly differs between the makeshift shunts, which we do occasionally when we are pushed to the wall, and others. So maybe you could take that question also. Is more follow-up forthcoming, or we have lost them for follow-up, or how do you go about ascertaining the long-term patency? Over to you.
Yes, sir. They are being followed up, sir. The most of the patients are on follow up. They have a file in our.
Only let me answer this question.
Yes, sir.
Yeah, go ahead.
Thank you, sir. I am Dr. Prabudh. So I was a resident when these were being done. So Professor Bhatnagar was the chief surgeon. So I requested him to be a part of this discussion. And after superannuation, sir, his patients are being followed up with Dr. Anjan. So he's also there in the meeting. So what Chandramouli has presented is what is written in the paper. So this was the follow-up when the paper was submitted. Two of these patients have been lost to follow-up, but I had a discussion with Anjan and 4 are still following up with us. As for the other question which was there in the chat box, whether decision is made intraoperatively or post-operatively. So I think it is a mix of the two. So what happens is whenever we have a patient of portal hypertension, we go ahead with a CT portogram to understand the vascular anatomy. We have radiology conferences where the radiologists and the pediatric surgeons get together, we discuss it, and we generally get an idea that the splenic vein is thrombosed or it is recanalized or it is not wide enough. And the thinking process starts from there on. The final assessment is intraoperative upon whatever is available at hand. And I think the final decision is on table.
Yeah.
So Bhatnagar might like to add something here.
Yeah, I think thank you, Chandramouli, for a very good presentation.
Thank you, sir.
See, the decision has to be on table. We do all these imaging studies, these fancy imaging studies with reconstructed things on the CT photography. It gives you a very good idea. But you know, the challenging part of surgery is that more often than not, you get a surprise on the table. And you have to be absolutely prepared for that kind of a situation. So I think in all these 6 patients, I think the final decision was taken on table, except possibly the one where we had no other vein but the right gastroepiploic vein. There we possibly went in with a premeditated idea that we have to use this dilated vein. The second thing is that in all my experience, what I have seen is that if the shunt remains patent for the first 1 year, and after that, if the hydration is maintained, the shunt usually does not get thrombosed later after the first year is over. So that in that respect, you know, because of various studies and this and that, we continue following up and wasting public money on getting these imagings done and things of that kind. But I don't, in clinical practice, if you ask me, I don't think it is necessary to follow them after 1 year because you're not going to do anything even if the child becomes symptomatic. So it's obviously a good idea to let the child go home, lead his normal life, and if he becomes symptomatic, he comes back to us. The other thing is that when you enforce a repeated follow-ups, very often it becomes difficult for the family to come again and again, because these are economically compromised people, and coming to hospital means quite a bit of an expense. And therefore, I think in the natural history, dropouts in follow-up are well known and well accepted, at least in our part of the world and in the kind of patients that we get in a government hospital. The other thing was that I think, and this is particularly for the postgraduates, I think you must understand the whole pathophysiology of portal hypertension and the requirements for treating portal hypertension. The main aspect is that because of at least in the EHPVOs, the portal vein is thrombosed, the portal pressures rise, there's the backflow, the splenic vein gets dilated. But there are conditions where the coagulation profile is altered. And some of these children are possibly in a hypercoagulable state. And that is seen when, and that is usually presumed when we find that the whole splenic vein is thrombosed. So that is something which one needs to take into account. If you are well prepared preoperatively, then it's easier for you to think or standing on your feet. But if you get a total surprise on table, then it's a difficult situation even for experienced surgeons. The other thing is that the basic fundamental of surgery in portal hypertension is to divert blood from the portal circulation into the systemic circulation so that we can reduce the portal pressures. Why do we want to reduce portal pressures? Because we know that elevated portal pressures can also give rise to biliopathy, gastropathy, failure to thrive, and a whole lot of other metabolic and kind of problems. So a reduction in portal pressure, diversion of portal blood into the systemic blood so that the varices don't bleed are the two main fundamentals of portal hypertension surgery. The technical aspects of the anastomosis again are very important because you have to give a very smooth flow of the portal blood into the systemic circulation. There should be no eddying. Your anastomosis has to be good so that it does not throw up clots and blocks the anastomosis. And that is why I think in children, at least, what we have experienced is that it takes about 3 months for a shunt to stabilize. And in my clinical practice, I have never used anything more than aspirin for more than 3 months. And I've been very happy with my results. Most patients have a patent shunt. The second
There's
important
one question.
Let me finish this. One more point. The other thing is that you have to understand the flow dynamics. The faster you reduce the pressures, the faster is the drop in portal pressure. And the faster the drop in portal pressure, the lesser is the flow through the shunt. And that is something which one must be very careful about. So if you make it too big an anastomosis, you are giving the child a very good flow in the immediate post-operative period, but the long-term patency will be under danger because once the flow across the shunt is greatly reduced, the chances of thrombosis become much higher.
So there's one question in the chat box from Ankur Mandalia about how does the IMV mesocaval, how does that shunt decompress the varices? Because the splenic circulation doesn't communicate with it. So maybe we could take that.
So that is why we prefer making a side-to-side shunt when we use the IMV. Because, at least in one of these children, there was rectal bleeding from varices in the rectum. And there it was important to decompress the varices in the area of the rectum. But if you use the IMV and make a side-to-side shunt, you are decompressing both the rectal varices and the esophageal varices.
Yeah. Yes, sir. Any other questions for the presenters?
Good evening, Professor Bhatnagar.
Good evening.
Good evening, Professor Bhatnagar, sir. I'm Dr. Sanjay Kulshesh from Agra. I have a small question, Professor Bhatnagar. In 3 of the cases, am I audible?
Your voice is breaking a bit, but you are audible.
This patient, in 3, you have a significant rectal bleeding due to anorectal varices.
We are not hearing properly. We are not audible, sir.
Oh, I just want to ask, is there any role of injection sclerotherapy in anorectal bleeding like that of varices? And is it the reason for choosing the inferior mesenteric vein in 4 out of 5 cases, Professor Bhatnagar?
So, like I said, I mean, you have no choice. You have very limited choices available for you when you're operating. And if you find a good inferior mesenteric vein, why not use it? It decompresses both the upper part of the body and the lower part of the body. And as far as the sclerotherapy for rectal varices goes, I don't think it's a very widely practiced option. But I guess if you don't have any means of decompressing the body pressure, then it might come in handy.
उस रूम में सर्वेंट उस वाले रूम में रखो, स्टोर रूम नहीं है वो उसको।
Okay, I think,
Sir,
sir, I
just
think we
one
should
point
move
if
to
I
the
can add
next
to that.
paper.
Sorry, sir.
Yeah.
Yeah.
No,
Sir,
no, Anjan wanted to say something.
Yes,
yes,
Anjan, go ahead. After that,
so,
we will.
yeah, it's regarding this sclerotherapy, sir. We had recently 2 cases, very atypical cases, presenting predominantly with again varices in the rectal varices. So in those cases, other than the rectal varices, it had florid extraluminal lesions also, extraluminal vessels. So they were approached mainly by our interventional radiologists to put gel foams into it. But however, what happened, the child definitely had an immediate relief, and we could get 3 to 4 months of window period to decide upon what to do next. But ultimately, the child had similar symptoms. A repeat injection sclerotherapy has been done, and we are now awaiting definitive management. So that is definitely possibly in a situation, life-saving situation, it might salvage those patients who are requiring massive transfusion in the emergency setting, but not
Thank you,
definitely
Anjan.
a definitive procedure.
Thanks. We'll move to the next paper now. Yeah.
Dr.
Vijay?
Raghu,
Thank
Dr.
you.
Raghu, I've made you the co-host. Kindly share your presentation. Second article is central pancreatectomy, a novel surgical technique, single institutional experience.
I'm just sharing my article.
Oh, please share it.
Sir, is it visible, sir?
Yeah, please.
Yes, it is.
Please,
It is.
please start.
Yes. So good evening, seniors and stalwarts. I'm Dr. Rahul, Assistant Professor of Pediatric Surgery in Institute of Child Health and Hospital for Children, MMC, Egmore. And I thank my authors, Professor Sendil Nathan sir, Professor Hariharan sir, and Shankar Badi sir from our department, and who are the surgical team. And I was blessed enough to be a part of one of the cases which we had operated. So I've just put an overview of our study. Solid cystic pseudopapillary neoplasm is what we are dealing with, and these children with these lesions, this is a rare, slow-growing, locally invasive malignant tumor, more common in adolescent females, accounting for only around 1 to 3% of all pancreatic tumors. And most of them present to us with vague abdominal pain, and few of them have non-bilious vomiting on and off. Ultrasound as a screening investigation had a mixed echogenic appearance, and further investigations revealed solid cystic pseudopapillary neoplasm in further investigations. So these are three children in our study. The first one was a 12-year-old female who presented with epigastric pain, and screening ultrasound was done, and the child underwent an MRI, which showed a variegated mass in the body and neck of the pancreas. An endoscopic ultrasound and FNAC was done, and diagnosis was proven, and further surgical management was done. The other 2 children, aged 11 years and 12 years, had more so periumbilical pain and epigastric pain. They didn't have any vomiting. Again, a screening ultrasound was diagnostic of a pancreatic mass lesion, and MRI was done in each of them, and possible diagnosis of a pancreatic tumor was done. So all of these children underwent central pancreatectomy with tumor-free resection margins. The surgical technique which we used, we opened the lesser sac, we palpated the mass in the body or in the body and neck of the pancreas, and the splenic vessels were ligated individually, and a pancreatic resection was completed with adequate margins using the vessel seal device. And tumor-free margin of 1 centimeter was achieved. The head of the pancreas was closed in a single layer with 4-0 prolin. And this is just to show you the overview of after the pancreatic mass resection. The head and the tail of the pancreas are visible. And further, the remnant pancreas was anastomosed to the posterior body of the stomach by a pancreatic gastric anastomosis through a posterior gastrotomy using 4-0 polypropylene sutures in 2 layers. And it was done by means of a dunking technique. because the pancreatic duct diameter in all of these children were less than 3 millimeters. And hence duct to mucosa anastomosis was not preferred and a pancreatic dunking technique was done. Histopathology was suggestive of pancreatic SPT with adequate tumor-free margins in all of these children. Two of these children were followed up 1 year later with an MRI to assess the residual pancreatic volume. And the approximate residual pancreatic volume in both of them was around 40 centimeters cube. And there was no ductal dilatation. And these children are on subsequent follow-up, the first child on 8-year follow-up, the second child on 2 years follow-up with no exocrine or endocrine abnormalities. The third child, unluckily at the time of discharge, acquired COVID and succumbed to COVID multi-organ dysfunction syndromes. Hence, SPT of Franz tumor, which arises from multipotent stem cells, it differentiates to both exocrine and endocrine lines. It is a slowly growing locally invasive tumor with no metastatic potential. And the treatment is resection with clear margins. This is just to put an overview of the WHO classification of the pancreatic neoplasms with the borderline tumor of a solid pseudopapillary tumor. So MRI is the investigation of choice. This is the T1 weighted image showing a large, well-defined encapsulated lesion with a high or low signal intensity and a T2 weighted lesion with a high signal intensity. Histopathology is the most conclusive criterion with a pseudopapillary arrangement with a bland appearing tumor cells, which was evident in all of our 3 children. The options for operating on these kids, most of them are major formidable procedures like a Whipple's procedure or a subtotal pancreatectomy. Because of the morbidity of the procedure and the probable pancreatic loss, we employed a central pancreatectomy with a pancreatico-gastric anastomosis. The advantages being the duodenal secretion is preserved. It preserves the duodenum and the remnant pancreas with good adequate pancreatic volume. And the tail being preserved, the islet density is more than 2-fold higher in the tail region. And there is always a debate between the pancreatico-gastric anastomosis or pancreatic jejunal anastomosis. With the soft pancreas, with a very small pancreatic duct of less than 3 millimeters, we preferred a pancreatic gastric anastomosis with a low incidence of pancreatic fistula evident in certain studies. In our study, with 3 children, there were no pancreatic leak. And just to quote a few studies, neither in these children with pseudopapillary tumors of the pancreas, neither post-operative chemotherapy or radiotherapy has been given in any of these children because complete surgical excision is curative unless they have a malignant component. And Whipple's or distal pancreatectomy, as we know, is associated with endocrine insufficiencies. The gastrointestinal biliary continuity is unaltered, thereby avoiding metabolic and nutritional complications in our children. And the chance of preserving the spleen is more when compared to distal pancreatectomies. So this is just to put an overview of the debate between the pancreatico-gastric anastomosis and pancreatico-jejunal anastomosis. Certain studies with the full-length articles suggest that pancreatico-gastric anastomosis has better non-leak rates when compared to a pancreatico-jejunal anastomosis. And PG anastomosis is performed easily. And with PG, the pancreatic exocrine secretions, they enter the potentially acidic gastric environment, which precludes the digestive damage of the pancreatico-enteric anastomosis by activated proteolytic enzymes. And pancreatico-gastric anastomosis also avoids a long jejunal loop, and post-operative gastric decompression can provide constant removal of the pancreatic and gastric secretions, avoiding accumulation and therefore tension on the anastomosis. And it also reduces the overall number of anastomosis in a single loop. And this is again to emphasize upon the fact, are we going to do a duct to mucosa anastomosis or a dunking technique? We prefer the dunking technique in 2 layers as pointed out because of the soft nature of the pancreas and a very small pancreatic duct. As evident in our studies, the dunking in these cases seems to have better leak rates. So to conclude, solid cystic pseudopapillary neoplasm in rare central pancreatectomy is a novel technique with adequate pancreatic preservation of the volume, thereby preventing endocrine exocrine insufficiencies. And pancreatico-gastric anastomosis is safe according to our studies because of the soft nature and the smaller caliber of the pancreatic duct. Thank you one and all for your patient listening.
Dr. Kulshrestha.
First question.
Good evening, Arun. It's a very excellent your study regarding the rare but important tumor. I have 1 or 2 questions. One is that you did MRI in all 3 cases. Am I audible? Am I audible?
Yes, sir.
You are audible.
Yes, sir. Please.
Yes,
You
sir.
did
Yes, sir.
MRI in all three cases, and
Yes, sir.
in one case you did FNSE. So did you plan for the type of surgery or the conservative surgery before operation, or you did per-operative fluorescein biopsy or para-biopsy to confirm regarding the plan of resection? Secondly, is there any need for nasogastric decompression to keep the gastric pressure low? If you feel regarding the rest of the stomach for the anastomosis as well as for the exocrine function of the pancreas. It's a different kind of anastomosis between the stomach and the pancreas. Do you feel it is an important aspect of this bowel rest? Please.
Sir, the first child actually had a biopsy done outside and then came to us, sir. We hadn't planned for a biopsy in any of these cases. And being an evident tumor with MRI being diagnostic in most of these cases, we went ahead with surgical management right away, sir. That was our plan. And with regard to gastric decompression, studies say it reduces tension in the anastomosis, but we were not worried about the anastomotic tensions. Gastric decompression is just a routine part, and it also there is a debate with regards to deactivation of the pancreatic enzymes on one end, and on the other end there is also reducing tension at the other end, sir. So it seems to be equivocal, but we had gastric decompression for 3 days post surgery, sir, in all of these 3 cases.
Okay, thank you. Do you use a drain of for this post-operatively?
There was an intraperitoneal drain, sir. We removed the drain on the 5th day because there was no secretion coming out of the drain, sir.
Okay, thank you.
There is a question in the chat box for you.
Yes.
Did the patient have heartburn, nausea, vomiting suggestive of gastritis? And I will add to that another point. The pancreatic juice coming into the jejunum would be more physiological than the pancreatic juice going into the stomach. So what is your take on this? I know you have talked about the meta-analysis of pancreatic gastrostomy versus pancreatic jejunostomy. So what is your take on these points?
Yes, sir. Pancreatiojejunal anastomosis, as you rightly pointed out, it's physiologically much more better when compared to pancreatic gastric, sir. But because of the smaller duct size and the soft pancreas, we felt it was safer to do an anastomosis to prevent leaks, sir, rather than filling on to the metabolic complications. And this is well accepted, sir. Probably we'll also try doing pancreatiojejunal in the next few attempts, sir.
Okay, there is. I will just ask you one more question, and Dr. Bhatnagar wants to ask something. See, you have done a central pancreatectomy.
Yes.
I presume all your tumors were situated there, and
Yes,
the average size is around 3 centimeters, which is not very large, considering that
yes,
spens are much larger than that.
Yes.
So, is it because of this location that you chose the central pancreatectomy? Could you not get just a clear margin to take it out without interfering with the pancreatic duct? That is one point. And so this is the point that I just want to ask, because most of the time you get clear margin and you can take out without disrupting the ductal system, especially for small tumors less than 5 centimeter, 4 centimeter. So then after this, Dr. Bhatnagar is going to ask you some questions and comments. Please go ahead.
This is absolutely regarding the location of the tumor only, sir. Because of this location, we went ahead with central pancreatectomy.
Okay. Sir, Dr. Bhatnagar?
Yeah. So my understanding of pancreatic surgery is that if the tumor or whatever the lesion which is requiring the pancreatectomy is to the right of the vein, then it requires a proper Whipple's operation. Because you have no other choice, because then you have to remove the head of the pancreas. But if the tumor is to the left of the portal vein, what is the necessity for preserving the tail of the pancreas? And remove the tail of the pancreas without doing a splenectomy. I mean, it takes a little bit more time, but I think it is perfectly possible to do it. The other thing is that we were talking about the dunking technique. In children, I think dunking technique is by and large preferred because the ducts are too tiny to have a duct to mucosa anastomosis. So that is perfectly fine to do a dunking technique. In fact, in all my Whipples that I have done so far, and there are, I think, 7 or there possibly an 8, I've always used the dunking technique to put the pancreas into the jejunum. And even in your case, suppose you take this as a preferred procedure, is it not more wise and advisable to take a loop of jejunum and put the distal pancreas in the loop of jejunum? Just telescope it in there, rather than putting it in the stomach and running the risk of various theoretical complications and side effects.
Yes, sir. We thought that because we had a considerable amount of tail, we thought excising it would be a little bit of increased morbidity because most of the beta cells are secreted at the tail, sir. But yes, you said your point is well taken. So if it is close to the tail, I think compromising that part is not of much an issue. And the other thing, we initially had pancreatic jejunal as our mind, sir. But because it is more closer to the stomach, and because the literature which we searched said that PG had decreased leak rates, we went ahead with pancreatic gastric anastomosis. Probably, so this is very early into our study. We had only 3 cases. So probably next few cases we will try pancreatic jejunal anastomosis to be more physiological, sir.
Dr. Ragul, there is a question from Dr. Lakshmi. Was the distal pancreatic remnant seen in the post-operative MRs? Because you have done the MRs in the 3 cases. Was it seen in the post-operative MR? And I will add one more question. You have mentioned in the manuscript that exocrine and endocrine functions were preserved pre-op and post-op. I understand about the endocrine. How did you do the exocrine? We find that is a very difficult thing in any of our pancreatic surgeries to quantitate the exocrine function. Did you really do something?
So we just did a fecal elastase, sir. Nothing, I mean, not much was being done. Only fecal elastase was done, sir. And we had, I mean, the pre-op and post-op values were not of much significance, sir. And with regards to the volume, yes, pancreatic tail was of adequate volume, sir. That is why the entire pancreatic volume was around 40 centimeters cubed, sir. Again, it was done only for 2 cases. The third child succumbed. So only for the first 2 cases, they had adequate amount of tails, the post-operative evaluations.
Okay, thank you. Good presentation. I think. Yeah.
Sir, I am Dr. Shankar.
Yes, please.
I was involved in one case. Sir, as Professor Bhatnagar has told that pancreatic jejunostomy, we have done one case after the series. That is an incidental, actually, 12-year-old girl, incidentally, we found a mid-pancreatic tumor. That case, we did a central pancreatiectomy and we did a pancreatic jejunostomy, sir. Thus, I want to tell that thing. After this series of 3 cases, we did that.
I think with this, we will move on to the next series. Next article, please.
So next article is by Dr.
I'd like to take your leave. I'm sorry for leaving midway, but I had some prior commitment. So thank you very much. And I really enjoyed this program, and I hope we continue doing it in future also. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you very much.
Dr. Yogesh Chandran.
Good evening, all. Good evening. Greetings from Pediatric Surgery Department.
Please keep
your make it full screen.
Slideshow.
Please make it full screen. Slideshow.
Is it now clear, sir?
No, not yet. There must be one icon below showing that full screen. Do it that. Bottom right.
Right bottom up.
Okay. Not able to do it. Then we'll continue.
It's near where it's written 46.
It's okay. You continue.
Yes, it is it. Yes.
Continue.
So greetings from Pediatric Surgery Department at Medical College Kozhikode, Kerala. Myself, Dr. Yogesh Chandran. Thank you for giving me this opportunity to present my paper in this inaugural session. My paper is on as percentage improvement in anteroposterior diameter, a valuable marker for successful drainage post-pyeloplasty in isolated pediatric pelvic ureteric junction obstruction. PUGO, like all know, causes increased chronic intrapelvic pressures, resulting in progressive renal damage. Surgical correction of which is usually done by the
Your
multi-center
slides are not moving.
pyeloplasty.
Your slides are not moving. Please.
Is it moving now, sir?
No.
No, it's stuck in the first slide. It is still stuck in the first slide. Just try and see if it moves.
Can I give a small solution?
Sure.
Can you go to slideshow? Go to slideshow. The top, insert design animation slideshow. Go to slideshow.
Now it's moving. It's
No.
not
Go to
slideshow, but it's moving.
slideshow. Go to slideshow button on the top. Take your arrow there. No, above that. Take it to the slideshow. Home, insert, design, animation. After that, slideshow. No, not this button, man. In the top. In the top ribbon, in the blue color ribbon. JIAPS paper PPT, it's written there, right? Go to the home button. Can you see the home on the top, written on the top? Top left. Top left, I can see in your screen. Yeah, go to the slideshow there. This is, everybody has to know this because this new PowerPoint and Zoom, there's a little bit of incompatibility and I found out how to figured out how to do it. But if you just listen to me, just go to the home on the top. On the top left, there is a home button. Move your arrow there. I think your arrow is also lost.
Just a minute, sir.
I just want to help you, man.
Stop slide share and then again share the slide.
Go to the slideshow home button. There's a home button on the top in the PPT.
Let him share the slides. Please share.
Yeah.
No, you have to set it up. You have to set up slideshow to browse by an individual. Then it'll all work. You just have to go to the top, go to slideshow and then choose browsed by the individual and then it'll work in the Zoom.
Or you can just email it to or WhatsApp to me. I'll do it from here. Or anyone else.
Dr. Yogesh, are you able to do it?
No, sir.
No, just
then go. I think we go back to your slides as you were showing them. We can still see them.
Yeah.
You can run without slideshow. That also is visible.
Just a minute, sir.
I mean, don't worry. It happens to everyone.
Yeah, absolutely.
Yeah. It happened
Sir,
to me many a times. Then Dr. Ramesh taught me how to fix it.
I have shared the slide to Rasik sir.
Okay, I'll. Just give me 1 minute. I'll do it.
Yes, sir.
Meanwhile, you can try this, what Ramesh sir was saying. You go to slideshow. And there is slideshow there, home, insert, then design, animation, and then there is slideshow.
Just 1 minute.
There's slideshow there.
Sir, Rasik sir, you can only share it if he stops sharing it. Then only you can share.
No, I know. Just give me a minute. It's opening up here. I'll just share it immediately once it is done. I will share. Can you see? Can you see?
Yes, we can.
Okay.
Yes, sir.
Go ahead. Yes, we can.
Dr. Yogesh,
Is it clear, sir, now?
Yeah, please start.
Can I begin?
Yes, please.
Yes, please.
So pelvic-ureteric junction obstruction, like it is known, it causes chronic increased intrapelvic pressures, which results in progressive renal damage. And the surgical correction of which is usually done by the Anderson-Hines dismembered pyeloplasty. It has a success rate of more than 90%. And follow-up cases is done with the help of ultrasound and diuretic renograms. And no standardized protocol exists for at present. A renogram, however, have certain disadvantages with respect to the availability, the cost, and the low dose radiations. However, the benefits of avoiding the radiation and the invasive nature of renography must be, and the increased cost must be balanced against the risk of not objectively measuring the differential function and the drainage postoperatively. The primary aim of a study was to determine if percentage improvement in APD is isolated unilateral pelvic-ureteric junction obstruction cases could be used as a marker for successful drainage post-pyeloplasty in pediatric patients, and further whether if PI-APD could replace the use of post-operative diuretic renogram. Next slide, please. Our study was a retrospective observational study, which was done in Department of Pediatric Surgery, Government Medical College, Kozhikode, a tertiary care institute in Kerala. All patients who underwent unilateral Anderson-Hines reduction pyeloplasty for isolated PUGO between June 2016 and May 2021 and are on regular follow-up were selected. Also, we had certain exclusion criteria, like we excluded patients who had bilateral PUGO, those who had solitary kidneys, those who had other urinary tract anomalies such as VUR, VUJO, PUV, duplex, etc. And also, in particular, we avoided patients whose differential renal function was less than 10% before pyeloplasty. Also, we avoided those patients who had pre-pyeloplasty diversion procedures, all patients with redo pyeloplasties, and all those who had early secondary interventions post-pyeloplasty. A total enumerated sampling of all the consecutive children meeting the criteria was done. We collected the patient details, including the age, the gender, the antenatal history, the signs and symptoms, the ultrasound, and the renogram parameters, both before and after pyeloplasty. APD, or the anteroposterior pelvic diameter, is defined as the transverse view diameter, which is bound by the renal parenchymal edges and distinct from the extrarenal pelvis. The percentage improvement in anteroposterior diameter, it was described by Romao et al. In his paper. It is defined as preoperative APD minus the postoperative pelvic diameter divided by the preoperative anteroposterior diameter into 100. This PI-APD of all patients were analyzed, and all these patients were grouped into 3 categories. The first category involved those who had a PI-APD of more than 40%. Group 2 included PI-APD of 20 to 39%, and group 3 patients included PI-APD less than 20%. Also, renogram parameters of all these patients were assessed, namely the differential renal function, the Tmax, the curve pattern, and any retention of dye in the delayed images. A successful pyeloplasty is defined by an improvement in differential renal function more than 5%, a decrease in Tmax, an improvement in curve pattern, and a decrease in retention. These 8 groups, that is the 3 groups, group 1, 2, and 3, were compared with improvement in the renogram parameters to look for any correlations between the two, if any. Analysis was done using IBM SPSS statistics. Proportions were compared using chi-square test. Mean values were compared using the paired t-test, and a p-value less than 0.05 was considered statistically significant. Can I move to the next slide, sir? The results, after considering the inclusion and the exclusion criteria, a total of 127 patients were included in the study. This included a data of 5 years of follow-up from our department. Of this, 73% children were male. Coming to the demographical statistics, most of these cases were antenatally detected, and mainly the age at surgery was between 1 and 3 years of age, which constituted almost 38.6% of cases. Clinically, most of these cases, as said before, were antenatally detected, and the most common symptom which we encountered was pain, which was seen in 11.8% of cases. Then we compared the anteroposterior diameter and parenchymal thickness in the pre and post-operative ultrasonography. In that, we could see a statistically significant difference. I would say a statistically significant decrease in the APD of minus 16.3 millimeters and a statistically significant increase in the parenchymal thickness of 2.1 millimeters in our subjects. Also, we compared the Tmax and the pre and post-operative, the function and the Tmax in the pre and the post-operative diuretic isotope renogram stage. And this also, we could find a statistically significant increase in the differential renal function of almost 5.6 and a statistically significant decrease in Tmax of 8.5 minutes. We also compared the curve pattern in the diuretic isotope renogram. And we had compared 4 parameters, namely the function, the Tmax, the curve pattern, and the retention. This third criteria, that is the curve pattern, in the preoperative DIR curve, we had 123 patients who had an upsloping curve and 4 patients who had a flat curve. Those 123 who had an upsloping curve in the preoperative DIR showed, of this, 113 cases showed a downsloping curve. And those with the flat curve initially showed a downsloping curve in the post-op renogram. Then we compared each PI-APD group, that is the 3 groups, to the function in the diuretic isotope renogram. While comparing, we could not find any statistically significant difference between the 3 groups when compared with the function in the renogram, as almost all of them showed an increase in function of around 70 to 80%. But while comparing the PI-APD groups to the Tmax in the diuretic renogram, we found a statistically significant correlation. That is, the group 1 patients. These group 1 patients, most of these patients were in the group 1. That is, 83 of these 127 patients were added in the group 1. Of this, almost 83% showed a decrease in Tmax. Also, the same was the scenario with group 2, where 83%, sir, I'm not finished with that slide. Can I go to the previous slide? Thank you, sir. In the group 2, group 2, 83% had a decrease in the Tmax. This, when compared with the group 3, only 7% had a decrease in Tmax, and 92% of them had an increase in Tmax in the group 3 patients. Can I move to the next slide, sir? We also correlated PI-APD groups to the tracer retention in the postoperative diuretic renogram cases. Here also we could not find a statistically significant difference among the 3 groups. Next slide, sir. And also, while comparing with the curve pattern also, we could not find a statistically significant difference between the 3 groups when comparing with the curve pattern in diuretic isotope renogram. Coming to the discussion part, sir, our study specifically showed a statistically significant reduction in the pelvic APD, that is minus 16.3 millimeters, and an improvement in the parenchymal thickness of 2.1 millimeters in our post-pyeloplasty subjects. Also, as said before, most of the patients, out of the 127 patients, 83% were in the group 1, which showed a PI-APD more than 40%. and also a statistically significant improvement in differential renal function of almost 5% was seen in postoperative cases, and also a statistically significant reduction in Tmax of 8.5 minutes was seen. While comparing the APD groups, that is the 3 groups with the improvement in the differential renal function, no significant difference was seen between the 3 groups with respect to the differential renal function. And when comparing APD groups with the improvement in Tmax also, there was a statistically significant correlation was found between PIAPD and PIAPD groups and Tmax. That is, most patients in groups 1 and 2, 83% in group 1 and 83.3% in group 2 showed an improvement in Tmax. However, most patients in group 3, that is 92.9%, showed no improvement in Tmax. Also, when comparing with retention, it was not statistically significant because none in groups 2 or 3 showed retention, whereas almost 9 patients in group 1 showed retention in the postoperative renograms. On comparison of the APD groups with the curve pattern in postoperative renogram, this was also not found to be statistically significant because 94, 90, and 85% of subjects in group 1, 2, and 3 showed correlation. Also, and to conclude, the patients with more than 40% improvement in PIAPD had a statistically significant improvement in Tmax, which is a marker of resolution of obstruction. And no statistically significant correlation was found between the 3 groups to other renogram parameters, namely the differential renal function, the curve pattern, the tracer retention in the pelvis. Our study found some certain similarities with that done by Romero et al., who evaluated PIAPD and postoperative pelvic APD as an early non-invasive objective predictor for the success of pyeloplasty. And what the findings in that study was that a PIAPD more than 38% or a postoperative APD less than 11.5 millimeter was associated with a good outcome. A similar study was also done by Rickard et al. He also explored different PIAPD ranges, and he found out that an APD more than 40% in the first postoperative review predicted a good pyeloplasty, good successful pyeloplasty, and a PIAPD less than 20% helped him in identifying all cases of recurrent PUGU. And as per the study, they believe that up to 85% of the renograms may have been unnecessary, and risk stratification based upon PIAPD would have been enough. Another similar study done by Mohazarat also concluded that early improvement in the pelvis cortex ratio and PIAPD can prevent the use of isotope scanning for a successful repair. And according to their study, they observed that a PIAPD more than 12% in 3 months or more than 26% could predict a successful pyeloplasty, which is a little bit less when compared to our study. Can I move to the next slide, sir? So to conclude, according to our study, a PIAPD range more than 40% at a statistically significant correlation with improvement in Tmax, which is a clear marker of relief of obstruction post-pyeloplasty. And also an improvement in renal parenchymal thickness is a clear indicator of a successful pyeloplasty. And we can selectively avoid follow-up of post-pyeloplasty patients with the help of diuretic isotope renogram in those subset of patients in whom the PIAPD is more than 40%, and in those cases where the renal parenchymal thickness has increased. Thank you, sir.
Thank you. Yes, I think we'll wait for Dr. Kulshrestha to come up with his comments and questions. Meanwhile, what is there in the chat box? There has always been concern that the ultrasound is very operator dependent. You have also acknowledged in the limitation that yes, it is operator dependent. So with that, not only that, don't you think the renogram itself is also operator dependent? Have all your renograms been in the same center? You have written that yes, all your ultrasounds in the same center. So there is some sort of standard practice. Are all your renograms also in the same center since you've correlated?
No, sir. Our renograms were not from the same center.
I see. So that also makes.
But we had taken care so that the ultrasound, all the ultrasound had been done from our same institution, sir. But the renograms have not been done from the same institution.
Okay.
If the parameters for the ultrasound and the criteria of the ultrasounds are same and the parameters are the same, then do you think it is a significant limitation if the guidelines for measurement and the parameters are the same? So if we have ultrasound from others also, so it could be the same, or more or less it should be should correlate.
Sir, according to our sir, the ultrasound is more of a subjective investigation, sir. So we believe that ultrasound taken from a single institute would be better than several institutes, sir.
There is one other question in the chat box.
But we could not done the renogram from the same.
Yeah. There's one other question from Dr. Manoj Joshi about from Dr. Parthapratim Gupta about the reduction in pelvis. You all had any standard way of reducing the pelvis? I know in the manuscript you have mentioned that you have measured the APPD in an area where it is intrarenal, so it is not outside. That is what you have mentioned. So how would you answer his question about reduction of pelvis and if it has affected your measurements?
Sir, actually, we think that the reduction of the pelvis has not got anything to do with APD, sir, because APD is the transverse diameter which is bounded by the renal parenchymal edges, sir. And so tailoring of the pelvis has nothing to do with reduction in APD, sir.
Okay, you have followed any particular thing about reduction of pelvis or it's surgeon dependent?
It is surgeon dependent, sir.
There's one, you have quoted Ricard Singh, and you have stratified your percentages according to Ricard's almost identical stratification. How is your paper different from Ricard's paper? Besides that, probably he has not used diuretic renogram parameters, right?
Sir, actually, sir, Ricard et al. Did not compare ultrasound parameters with, specifically compare ultrasound parameters with differential renal function parameters, sir. In our paper, we compared. In our paper, we divided the subjects into 3 groups and we compared each group with the renogram parameters to be more specific, sir, and to know whether each group correlated, how each group correlated with the renogram parameters, sir.
Right. There's one more question in the chat box. How many in group 3 required redo in follow-up? Group 3 is the last group which had poorer results, I suppose.
2 of our patients needed a redo pyeloplasty, sir.
Yeah, you have described. One is one is 1 year and another one is 3 months. They had different results. So as a corollary to that, did infants, we see that your age group, average age is 2.5 years, 30 months for surgery, average age at surgery, which is much beyond infancy, where you find recovery to be the best in PUJ. So in infancy, which is around 30% of your patients, was it any different from the rest, or there was no such difference that you found in this improvement? Except those 2 patients who didn't do well and required a redo. Generally, was it any different? Have you stratified it that way, or you have not done it that way?
No, sir. We did not stratify patients based upon the age group, sir. We did not.
I see. There's another question from in the chat box. Can we confidently stop doing nuclear renogram? This is from Dr. Asiksha to follow up as a result with your study. As an author, would you say your study leads us to that direction, or would you suggest more studies with more controls?
So we believe that those patients who had a percentage improvement in APD more than 40%, along with an improvement in the parenchymal, renal parenchymal thickness, and asymptomatic patients, I think these patients can be excluded for renogram studies, sir, post pyeloplasty, and these patients can be followed up with ultrasound parameters alone.
Right. So the subset of patients who seem to be doing well. There was
Yes, sir,
another query about the APD changes with age. So how would you answer that if someone asks you that if at different ages you have different APD, so how do we compare?
Sir, the maximum, according to the available literature, sir, the most common age group where there is a recurrence of PUGO is within the first 2 years post pyeloplasty, sir. And within that age group, within that time period, there is very less difference in the APD based upon the growth, sir.
Okay, I think another big thing is that you have used a ratio. So mathematically, that takes care of this age and variation and APD variation. You have used a ratio, so that takes care. That PI takes care of this
yes, sir.
Mathematical problem, right? There's another question there. How many days post surgery did you do the scans or renogram? You have mentioned that in methods. You can just.
Sir, we usually do renograms post pyeloplasty after 6 months from the date of pyeloplasty, sir. And we had taken care so that the ultrasound, which was done most proximate to the renogram, was taken for consideration, sir.
Any other questions from anyone, please?
I just have a comment.
Yeah, please.
Yeah, I mean, the conclusion, what you said is very correct. I mean, if there is a good improvement in percentage improvement in APD and there is improvement in cortex, then you can probably reduce the number of renograms. I mean, that kind of statement is correct, but I don't know whether we can replace the renograms, particularly in the remaining group. Now, one more point is in infants, there is a very good improvement in diameter. Also, as your follow-up increases, like for example, at a 1-year follow-up, your ultrasound improvement is also much more than your 3-month follow-up. Then one more point is like, you know, the APD measurement has to be accurate. So you need to have a proper sonologist, and then the same person has to be repeating it, because the renal pelvic diameter itself can be quite differentiated between the two sonographers. And somebody has already mentioned that reduction pyeloplasty, non-reduction pyeloplasty, although you feel that it may not have an impact on it, you know, reduction pyeloplasty does have an impact sometimes on the measurements as well, because the pressure, the way the pressure transmitted either proximally or distally is different in each method. So, but your final statement, I agree that, you know, if there is a 40% improvement in function in APD, then probably in those, if there is a cortical improvement also, we can limit the number of the radionuclear studies, which is quite invasive. That's my comment. Thank you.
Yeah, I think there is one point in our editing which we have missed from the journal's point of view. I think here and there it is mentioned as dye instead of radioisotope. So that is one thing that we could correct. Yeah, and if there are any other questions, we take them. Otherwise, I pass it on to the coordinators. Vijay?
Sir, Manoj sir, please.
Yeah, so should we conclude the section?
Yeah, please go ahead and conclude the session.
Yeah, thank you, sir. So, dear senior colleagues, at the outset, I would like to